At the outset, I would like to congratulate your young team to put up a stellar show here, and it's really nice to see how great work you all are doing. I would also like to acknowledge a tremendous help by my colleague, Dr. Nandini, to make this presentation. Basically, when we talk about the emergency following refractive surgery, why do we need treatment? Well, if we do not do treatment, we may end up with significant morbidity. And hence, in emergencies, you will require emergency actions also. By definition, what do we mean by emergency in the refractive surgeries? These are the conditions which would require immediate attention or treatment. And if it is not treated on time, well, it will significantly compromise vision or quality of life. Mind you, these patients are normal young patients, and if not treated, they can significantly get affected. Now, I'm going to take up these things in two phases, one before flap and another under flap, and I cannot take up everything, hence I'm taking up the important aspect only. One of them is epithelial defect. Now, epithelial defect can occur intraoperatively because of overuse of topical anesthetic drop or your marking or suction ring, microkeratome, even handling of the flap using any forceps or the dehydration. So remember, do not put unnecessary anesthetic drop multiple times prior to the surgery. One drop just before is good enough. Do not allow the flaps to get dehydrated, and they would lead to such kind of epithelial effect. Another thing during the surgery or the end of the surgery, which can lead to epithelial defect, is speculum removal. Simple thing like speculum removal can actually lead to epithelial defect. Now, depending upon the site of epithelial defect, if it's a central epithelial defect, it can significantly affect the visual quality. If it's a peripheral defect, it can have potential of having an epithelial ingrowth and hence need to be treated. Treatment-wise, well, the drops, whichever you're using, preferably should be preservative-free. So if it's an antibiotic, moxifloxacin, or the lubricants without preservative are good. Bandage contact lens are something which are mandatory in these cases, and it's better to put bandage contact lens. When you have epithelial defect, they can have significant pain, and hence systemic analgesics like gabapentin can work wonders. What happens if we do not treat them? Well, if we do not treat the epithelial defect, there can be chance of stomal melting infection. There can be chance of DLCAN, which is extremend common whenever you have epithelial defect. And in the area of epithelial defect, you will have diffuse lamellar keratitis. You can actually end up with a recurrent corneal erosion also in such kind of cases, and hence need to be treated. Coming to the next part, which is flap dislodgement. Now, flap dislodgement can lead to significant discomfort, pain, decreased vision, and it's an emergency where patient comes to you with such kind of thing, and possibly in emergency hours also. Now, if that occurs usually in the early 24 hours, that's usually related to lid squeezing, eye rubbing by patient, or forceful blinking also. But later on, usually it does not spontaneously dislodge, and it's most commonly related to trauma. Now, incidence-wise, it's not very common, but it can happen. The outcome of treatment in earlier dislodgement is much better than somebody presents with much later presentation. Well, how do we treat? If it's a partial dislocation, you have to repose the flap as early as possible. However, please lift it up, wash it thoroughly with saline as well as antibiotic. If you want to put, you can just put there, and put a BCL. Make sure there are no trapped epithelial cell underneath. Now, if it's a complete flap dislocation, and if patient presents a little later, and if you have lost the landmark there, then it becomes a little difficult to put it, and the outcome may not be as great. Also, there can be very high risk of epithelial ingrowth and significant distortion of the flap, as well as visual disturbance. Such kind of flap may require suturing and BCL. Improperly reposited flap can lead to astigmatism. So what happens if we do not treat the flap displacement? It can lead to fixed folds or epithelial ingrowth. The next part is the flap striae. The flap striae can be pretty common, especially the microstriae. However, the macrostriae may not be as common. They are easily diagnosed on slit lamp as well as on the retroillumination, fundus retroillumination, or on slit lamp or on surgical microscope. They can be wonderfully seen. They can lead to irregular astigmatism or distorted mias. They can also be seen on fluorescent staining. Now, treatment-wise, we have to debride the epithelium. That's very important. Otherwise, it goes into fixed fold. Now, during that, it's better to dilate the patient so that you can have retroillumination. Do not do under surgical microscope of your LASIK machine, but your normal OT microscope is better. Lift the flap, hydrate the flap, repose it by stretching it, and if required, you can put suture or fibrin glue also. Coming to beneath flap, the diffuse lamellar keratitis comes to the first of thing which can happen. Though it's an idiopathic inflammation, it usually happens earlier in the post-op period, and patient can be asymptomatic or can have mild irritation or pain. Usually related to things like your surgical intervention with betadine drapes, powder, your mebamin secretion, the epithelial defect, as well as the intra-procedure. It can be divided based on the staging. If it is very mild and in periphery stage 1, a topical treatment is good enough. Stage 2, which is little diffuse, you may have to use more of a frequent steroid. Stage 3 may require systemic steroid, and you may have to lift the flap. And stage 4 usually requires scraping as well as lifting of the flap, as well as systemic steroids. Treatment-wise, as I told you, the lifting of the flap requires washing and removing of all these noxious material, and continue with your topical as well as systemic steroid. Coming to the next part, which is central toxic keratopathy, which is pretty commonly confused with diffuse lamellar keratitis. However, it's a unique feature that it's a non-inflammatory. It can be confused with stage 4, but remember this picture, when you see such fixed folds, deep folds, it's nothing but central toxic keratopathy. It is something which does not require flap lift. So unnecessarily, please do not lift the flap. It does not respond to steroids. So unnecessarily, do not pour too much steroid. It can occur with LASIK, PRK, SMILE, anything. And at long term, it resolves on its own with the hyperopic shift. Management wise, it's wait and watch, nothing much you can do. Reassure the patient, and they should be fine. Next is the pressure-induced stomal keratitis or interface fluid. It can look like DLK, but it usually would be bilateral and would be associated with raised IOP. Many times the IOP can be underestimated with GATs, so you may want to use your tonopen. But the best diagnosis is done using an ASOCT. On a careful slit lamp examination, you can see the pocket. Treatment-wise, stop the steroids, start anti-glaucoma, and patient should be fine. The next part is more dreaded complication, which is microbial keratitis. The microbial keratitis can be devastating and sight-threatening. It can happen at any step, and it can be influenced by anything from your microkeratome blade, which is reused if at all, your topical treatment, bandage, contact lens, epithelial defect, interface fluid, anything can lead to such kind of thing. Early onset usually is related to gram-positive organisms. Later on, it can be mycobacterium and fungal. The treatment earlier is better. Usually such kind of thing requires flap lift, and which reduces the load of organism, as well as it gives you better yield in your management. Finally, some peculiar presentations like BADI or BAIT, which is sudden pigment dispersion, usually occurs because of moxifloxacin, either systemic or topical. I would like to acknowledge Dr. Nimrita, my ex-fellow and good friend, who had such kind of complication in a few of her cases and presented beautifully. And it leads to significant pigment dispersion in the eye and ultimately leads to significant raised IOP, which may not come under control with whatever medication you use. Remember, the culprit here was BCL soaked in moxifloxacin. So every time pouring moxifloxacin on the surface may not be the best idea. To conclude, complication following keratorefractive surgery can be emergencies leading to significant ocular morbidity, and appropriate treatment can prevent the ill effect. Prevention is always better than cure, and treatment is always better than no intervention. Thank you very much.